our first speaker, who's an absolute rock star in CNS radiation oncology, Dr. Rupesh Kotecha. He's a board-certified radiation oncologist and chief of radiosurgery in the Department of Radiation Oncology, and he's a director of Central Nervous System Metastasis Program at Miami Cancer Institute. He's a professor in the Department of Radiation Oncology and Translational Medicine at the FIU Herbert Wertheim College of Medicine, and an adjunct faculty in the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center in New York. He's also an investigator on the registry study, so join me in welcoming Dr. Kotecha to talk about brain metastases and the management.
Well, thank you for that introduction, and thanks for being here today. So we're actually dividing this session into two different topics, brain metastasis and then GBM. So first, let's start with brain mets. Let's see if I can get this to go. Okay, these are my disclosures, and obviously here we're highlighting GT Medical Technologies as the manufacturer of GammaTile, something that we'll talk about today. So this is our cancer center in Miami, and you can see here our building. In the radiation oncology space, we have traditional external beam radiation therapy. We also offer radiopharmaceutical therapy, and then we also are considering tumor treating fields as part of our armamentarium. And you can see here, right in the middle of this is GammaTile. So we were a very early adopter of this technology, but also we've been fortunate to be using it for 5 years now. So we have outcomes from our institution as well as others, which I'll show you today, which really have demonstrated the utility of this technology as it is. In the brain tumor space, we have a variety of external beam radiation therapy treatments that we can offer for our patients. The unique aspect of brachytherapy is that the radiation is actually implanted at the site of the tumor itself, so it gives the most directed form of radiation therapy. This is kind of our historical workflow. As I mentioned, we started the program 5 years ago, and it used to require us actually doing MRI scans and contouring the volumes up front and determining with our physicists what would be the appropriate strategy to be able to treat the patient with regards to the tile estimates. This is much more simplified in the new workflow, which our physics team is actually presenting at this meeting. So not to give you too much information, but we have looked at this systematically with regards to what is the different method and which will be the best method actually to estimate the tiles that were needed. And so this, I point you to this conclusion here that the lookup table is the most consistent way of actually overestimating the amount of tiles, which will make sure that you are not missing any tiles for your case. And so I think this is what is key, this is what is important, this is an efficient workflow. Actually, Michael Garcia, who just introduced me, is the one who presented this at the ABS meeting, and this is what we have actually moved to at our institution. It allows us to be able to identify the number of tiles that we would need simply just looking at the MRI and doing a quick unidimensional measurement. And this allows us to then quickly order the tiles and then able to book the case in a very short amount of time. So going through the settings for how we offer or think about brachytherapy for brain metastasis, we have the upfront setting, and we try and use it as a way to dose escalate the large resectable brain metastasis that we are treating. In the recurrent setting, it's a little bit different. We want to pathologically confirm that the patient is actually having a disease relapse. And then secondly, in the setting of a radio-resistant tumor, we want to dose escalate these patients to help reduce the risk of a future local recurrence. So let's talk about the upfront setting. So what has really made the standard of care for this patient population? Well, the MD Anderson trial, which randomized patients in the post-resection setting to observation versus stereotactic radiation therapy, which did demonstrate a benefit to use of focal therapy, although the 1-year local control is modest at about 72%. We also have the N107C study, which randomized patients to whole brain radiation therapy versus postoperative stereotactic radiosurgery. And although radiosurgery was beneficial with regards to neurocognitive preservation, you can see the local control rates at 1 year at about 60% are also pretty modest and suboptimal. A key caveat to this is when we're looking at the actual failure rates based on the cavity sizes, those cavities that are more than 2.5 centimeters in max dimension have a very high rate of local failure. And in fact, at 1 year, it's just under 50%. So Minash Mehta, who is somebody that I work with closely, he tells people that basically if you get focal radiotherapy, you could flip a coin to see whether you're actually going to be controlled or not just 1 year after treatment. We also know that from phase 2 studies looking at the location of brain metastasis that are about to be resected, whether the lesion is superficial or deep, also does influence the ultimate rate of local failure. Now, one would argue that we have shifted as a field to the use of preoperative stereotactic radiosurgery, and although we are awaiting the results from the N012 trial, which will ultimately prospectively evaluate this, I want to remind the group here that we think about the benefits of preoperative radiosurgery in a composite sense. It reduces the rate of radiation necrosis. It reduces the rate of meningeal disease recurrence. What it does not do in comparative series is reduce the rate of local recurrence. And in fact, in this series, which is the largest comparative series between preoperative and postoperative radiosurgery, the 1-year rate of local recurrence is technically and numerically higher with preoperative radiosurgery than postoperative radiosurgery. So it still is something that we need to battle with, even if we consider shifting to the preoperative setting. And at our institution, when we have a patient who's diagnosed with a large brain metastasis, something that we quantify as more than 2 centimeters in max dimension, we have a variety of options. We can offer FSRS, postoperative FSRS, preoperative dose-escalated single-fraction SRS, or staged radiosurgery. And we did a large comparative series, as you can see here, published in JNO at the end of last year, really looking at all of these approaches, and they're all very similar with regards to the outcomes. However, for those patients that have lesions more than 2.5 centimeters max dimension, again, we see suboptimal control rates with all of these modalities, and therefore we do consider in our workflow, in our institutional paradigm, to consider these patients for surgery and immediate postoperative brachytherapy as a means to maximize the local control. First, we put some dosimetric work into this to see what are the areas that we would have higher doses of radiation, with areas where we have lower doses of radiation. How does this compete with current modalities? So our institution, we have CyberKnife, we have a GammaKnife. There's actually pre to us installing the ZAP as well. And we also put in proton therapy here. And you can see here, obviously, all of these techniques, they differ with regards to the energies, the delivery technique, the dose algorithm, optimization. Another issue is that some of these are external beam radiation therapy treatments, and obviously brachytherapy dose is different, and you have to recalculate that to get something that would be equivalent for you to do comparative analyses across the different technologies. And so ultimately with this analysis, what we saw is that with the 3 millimeter region around the resection cavity, you get a higher biologic effective dose to the tumor resection cavity. At 5 millimeters, it's very similar to other external beam radiation therapy modalities. And beyond that, it drops to essentially 0, like any other brachytherapy that we'd consider. So again, think about this. The highest dose region, we're actually dose escalating, is that 3 millimeter region around the resection cavity. Why do I think of that as being important? Well, if we look at postoperative stereotactic radiosurgery series and patterns of failure, if you're actually looking at covering where tumors recur after surgery and postoperative focal therapy, 91% of recurrences happen within that 3 millimeter margin or that 3 millimeter region. So that's the area where we fail, and that's where you can get dose escalation with brachytherapy. So I'll give you an example here. This is a 66-year-old male with renal cell carcinoma, so a radio-resistant tumor, has a very large left frontal brain metastasis. You can see here just on bidirectional measurements, it's 4 by 4, and I would tell you actually soup to imp was also 4. So this is a very large tumor from a volumetric standpoint to offer, for example, preoperative radiosurgery. You can see here we offered this patient surgery and immediate brachytherapy. You can see the dosimetric assessments here below. And then with long-term follow-up, this is what you want to see, a nice clean resection cavity. You don't see any irregular enhancement surrounding that resection cavity. You don't see areas concerning for radiation necrosis or equivocal changes. This is a nicely controlled large brain metastasis in a radio-resistant tumor. We looked at this actually in patients who were treated in a salvage setting with brachytherapy compared to patients who were very similar but treated in the upfront setting with postoperative fractionated radiosurgery, what we consider the best standard of care for these patients. And if you look at similar patients, so 16 matched with 36 patients, essentially the patients who were treated in the recurrent salvage setting should have lower rates of local control and should have higher rates of radiation necrosis. Yet we see similar rates of local control and similar rates of radiation necrosis. Despite this being an apples to pears comparison, we're comparing recurrent patients who have already undergone and failed radiosurgery versus patients who are treated in the upfront setting with postoperative fractionated radiosurgery. So we presented this data at ASTRO earlier this year. And data such as this led to the design and ultimately to the completion, as you heard at the intro, of the GTM 102 trial, which is a phase 3 randomized trial in the immediate postoperative setting to the best standard of care, which is fractionated external beam radiation therapy, versus brachytherapy or START. The primary endpoint for this study was surgical bed recurrence-free survival. And as we heard, the study has completed its accrual, again, something rare in the brain metastasis space, especially in the post-surgical setting. And we await the results eagerly for this trial. So now let's move to the recurrent setting. So brachytherapy actually gives us the ability to pathologically confirm whether the patient's actually truly having disease relapse, but also allows us to dose escalate these areas. Now, it's common to see patients who have equivocal changes after radiosurgery, and an increase in lesion size is becoming extremely common in our practice. About 1/3 of brain metastases do increase in size after radiosurgery, and since patients are treated in the modern era for multiple lesions, at least 1/2 of our patients are now told at some point that at least one of their treated lesions has increased in size. Typically, this occurs in the 3 to 6 month window, but can occur as early as 6 weeks and can occur as late as 15 months after radiosurgery. This is nice data from Yale collapsing 500 brain metastasis in 120 patients, basically showing that there are 3 different time points that we see an increase in lesion size after radiosurgery. Now, the problem is it's very difficult for us to tell if the patient has an increasing tumor size. Is that truly tumor progression, or is that adverse radiation effect or radiation necrosis? Most patients get standard MRI alone, but 6 features are common on standard anatomical MRI between these two phenomena. The increase in contrast enhancement, the increase in the size of the lesion, the location being the original site of disease, the fact that this occurs in the area of the highest radiation dose, that this does result in surrounding vasogenic edema and can be associated with mass effect. But differentiating between these is critical for understanding what to do with the patient. Now, there are a variety of other options you can use. For example, dynamic contrast imaging, diffusion rate imaging, MR spectroscopy, and even PET or SPECT. And you can have algorithms such as the one that I'm showing you on the right here. This is the one I was trained on at Cleveland Clinic that kind of work you through how to manage a patient in this setting. This is an example of a case of mine. So a patient with metastatic non-small cell lung cancer had a craniotomy, had resection of a brain met, had postoperative radiosurgery, recurred 2 years later, had another resection, pathology-proven disease, had another course of radiosurgery, and then presented 2 years later with symptomatic disease progression. They were sent to me for a second opinion. You can see the MRI with contrast showing an enhancing area in the right parietal lobe. There is significant surrounding vasogenic edema, and we did a MRI with CBV, which is elevated in that region. So using what I was trained on, this patient had radiosurgery, it enlarged. We did a short-term follow-up, it worsened, and we did an MRI with CBV, and you would think the patient had tumor progression. We sent the patient to surgery. You can see the pathology here. This patient just has gliosis and necrosis, no evidence of actual residual or recurrent disease. Now, in the modern era, what I recommend is that we use more than one imaging modality if we don't have surgical pathology. So you can integrate newer things like CEST imaging as well as amino acid PET imaging. And we recommend actually doing 2 or 3 of these tests in addition to standard MRI alone to help make a diagnosis. But still, this is not perfect. This is actually a really nice data that came from UCSF at the end of last year. A phenomenon that they actually retermed radiologic uncertainty. So patients had radiosurgery, they have a growing lesion, and you don't know whether this is truly tumor progression or radiation necrosis. Again, this is at a high-volume academic center, and 6 months after making this diagnosis of radiologic uncertainty, they still don't have a diagnosis in 25% of patients. That's a pretty significant proportion. The issue is that this is not just radiologic alone. There's actually multiple neurologic deficits that are observed in this patient population. And ultimately, when you decide to act on this patient group and offer another intervention, the rate of having a neurologic deficit as a result of your repeat intervention is 40%. So I love this term, radiologic uncertainty, but there's also a clinical aspect to this, which is missed using that term alone. This is a patient of ours. So patient had a left cerebellar brain metastasis. You can see there, irregular in shape, treated with radiosurgery. You can see the post-treatment MRI scan. It looks very similar. And in fact, actually, the enhancement pattern has worsened. We did an MR with perfusion, and actually every MR that we do at our facility also includes perfusion. So we had the comparative perfusion imaging, and this actually worsened with time. So we had a baseline, we have a post-treatment, and we have a subsequent MR that shows increasing cerebral blood volume, concerning for residual recurrent disease. Even with this alone, this patient was then signed up. They actually were enrolled onto the GammaTile registry. We did surgery, and we're planning to do brachytherapy. But look at this. This patient actually had just necrosis and gliosis. If you didn't put the patient through this, you would actually just retreat this patient with external beam radiation therapy and potentially worsen the necrosis. So we thought this was very interesting, and actually we asked to go back through the GTM 101 data set to see could we learn something from the registry. I think this is actually one of the very few scenarios in radiation oncology that we can actually use screen failures from a prospective study to actually inform our practice. So these patients had prior radiation therapy. They had a growing lesion. They actually were presumed to have recurrent disease based on their enrolling institution, so much so that they were being put through surgery, enrolled onto a therapeutic trial, and planned to get brachytherapy for salvage. So you needed to have a very high bar to be able to put a patient through this. And yet, once we had the intraoperative pathology, we had patients who fell out. They were screen failures because they had only radiation necrosis on that final pathology. So similar to the case that I showed, we looked at this in a pool set of just over 60 patients, and necrosis only was actually found in 12% of that patient population, 16% in lung, 13% in breast, 11% in melanoma. So I think even with our best standard of care imaging at high quality, at large, high volume centers, we still are not sure, almost 15% of the time for our patients, if they truly have radiation effect or necrosis. These are guidelines, and this is how we've updated our practice since. So I know this is very small, but this is actually our set of guidelines in 2017 when our cancer center first started. And we would follow this. We'd say if the patient had prior radiosurgery, they had an increase in lesion, they had a local failure, what do we offer? And so we had a variety of options. We tried to put these in place to really systematize our practice. And again, in 2017, we didn't have brachytherapy, and so although it's very small here, if a patient had a local recurrence, we actually offered surgery alone as one of the options for those patients. However, we now have two more recent data sets that have come out in the past couple of years, one from MD Anderson and one from MSK, showing that this is really not an optimal approach. About 40% of patients will subsequently have another local recurrence if you offer even a gross total resection in the recurrent setting. So we've changed these, and this is now we've published in Neuro-Oncology at the end of last year that these are the new guidelines or the new consensus actually between US and European institutions and centers, even who do not have access to brachytherapy like we do in the United States. But you can see here that now brachytherapy is one of the options in addition to external beam radiation therapy after surgery for a recurrent brain metastasis. Again, going back to the dosimetry, I'm not going to push this as we talked about this earlier, but again, you get a higher effective dose in the resection cavity and in the peri-resection region with GammaTile brachytherapy compared to other external beam radiation therapy modalities. So we actually have clinical outcomes now from a couple of centers that help to verify what we've seen in the dosimetric analysis. There's a prospective registry of 20 patients at MSK, 24 operations, 25 tumors, a median preoperative tumor size of 3 centimeters, prior SRS and FSRS in all patients, so these are recurrent tumors. 80% underwent a subsequent gross total resection or near total resection. The 12-month failure rate is 8.4%. That is pretty good in patients who had maximal upfront radiosurgery. Let's give you another experience. Ours at MCI, actually our very early experience, 10 patients, 12 tumors, very similar median preoperative tumor size of 2.7 centimeters. We had prior radiosurgery and potentially whole brain and potentially multiple courses of radiosurgery for patients before. We had a gross total resection in all patients. And these are actually the same patients plotted against their initial course of radiosurgery. And you can see out to 18 months, we had no local failures in this patient population. Finally, we have MD Anderson, and they have reported their more recent update, 31 patients, 38 tumors. They reported a volume. If you equivalent this, you get basically 2.6 centimeter sizes, so very similar tumor sizes between the three institutions. Prior radiosurgery in all patients, gross total resection in 84% of patients, and then their 12-month local control rate was 13%. Again, very similar to what we saw with the MSK data. So putting it together, this is actually our modern workflow. So a patient who has a brain metastasis ultimately undergoes radiosurgery as their first-line treatment. If we are wondering whether the patient has locally recurrent disease versus radiation necrosis, our current workflow actually is to offer an amino acid PET CT scan for these patients. And if we have congruent imaging between amino acid PET plus their MRI with CBV plus the MRR itself, then we end up enrolling them onto the GTM 101 registry. We offer them surgery and brachytherapy at the time of salvage. So this is an example of ours. So this is a patient with a very small left frontal brain metastasis. Something that you would think, 24 grain a single fraction, that control rate should be over 90%, closer to 94% probably. You can see that radiosurgery plan. You can see the post-treatment MRI scan. We debated whether this is radiation necrosis versus actually tumor progression or recurrence. Actually, prior to us offering amino acid PET scans, we would do FDG PET scans, which I think in general are useless unless they're very positive or very negative. This one is very positive. And obviously you can see the red area on the CBV consistent with recurrent disease. This patient obviously had an implant because they had truly recurrent disease. And you can see a nice follow-up MRI scan that we were able to salvage this patient long-term and has not had a recurrence despite a very early recurrence after maximum single fraction radiosurgery. And I think that is, and with that, we are contributing to prospective trials in this space as well. So this is the MSK 2542 study. This is a study that actually is accruing very well now in the recurrent setting for patients who have brain metastasis previously treated with radiation therapy. They're enrolled and then randomized in a 1-to-1 ratio of either surgery plus whatever's the continuation standard of care, whether it's systemic therapy or external beam radiation therapy versus surgical resection and brachytherapy. So this study, we are participating in addition to Memorial Sloan Kettering as the leading institution, and hopefully will provide practice-defining evidence in this space in a randomized fashion as to how do we approach these recurrent brain metastasis. And thank you.
One question I had for you. Clinically, we get asked a lot, what % of viable cells need to be present at time of resection to implant?
Yeah, so this is very controversial. For example, in the MSK study, we actually have a percentage. A lot of institutions sometimes use 5%, sometimes use 1%. I think quantifying that at the time of surgery, when you just have a frozen section, is very difficult. For us, what we've used, and this is actually from original UCSF paradigm, if you have any residual or recurrent viable tumor cells on the frozen pathology with the initial sections, then we will go ahead and implant that patient. From the literature, you can see actually if they have any biopsy that shows any recurrent disease and they don't have the full histologic sample, those patients are at very high risk for recurrence shortly after lit. And so I think that gives us the evidence to be able to implant these patients as long as you have any residual or recurrent disease.
Thank you so much. Another question that I had is you presented some very strong rationale and data and evidence supporting the use of resection plus GammaTile for recurrent brain metastases, really better local control than what's published in the literature for other management strategies. Yesterday, there was a session on reirradiation for brain tumors, including brain metastases. And really, I was surprised that GammaTile was not discussed more. It was really mainly like this gestalt of, this is what I do in my practice, really lacking in data. And so I wonder, given the strong reproduced data as you showed from your institution, MSK, BNI, and others, what is it going to take for radiation oncologists to integrate this into their practice and practice evidence-based medicine?
It's a good question, actually, because we've had such good outcomes in the recurrent setting, both at our institution, and you see this at MD Anderson and MSK. It was actually very difficult for us to decide to participate in the MSK 2542 study because we were going to randomize patients against what we have already moved to at our institution as the current standard of care, which is resection and brachytherapy. The reason why we ended up joining that study is that we still believe that for other institutions and for the entire radiation oncology community to adopt this further, we need to have randomized evidence. You know, the fortunate thing in radiation oncology is that we like randomized evidence to push and move our practice. And so that's why for the community, we decided to contribute to that study. And I think once that study completes and if we have the outcomes that we are expecting, based on how the experiences have been, I think that will help to promote clinical practice to shift. I think what I tell people in the recurrent setting is that it's not just the fact that you're going to have further recurrences, it's also the issue that you can further increase the risk of radiation necrosis. And so the risk of a local recurrence in the reirradiation setting with additional external beam radiation therapy is anywhere from 15 to 30%. The risk of additional radiation necrosis is probably about 20 to 25%, maybe even up to 30, 35%. Now, some people say there are some series that even 40% risk of necrosis, and maybe that's because they didn't select well and they had maybe treated patients who actually truly had necrosis. But ultimately, if you add those numbers together, so take 25 plus 25 or 25 plus 30, that's about half of the patients are going to have an adverse outcome if you just repeat external beam radiation therapy, either with necrosis or with further tumor progression. And again, you're not doing the benefit to the patient if you're offering them a treatment that has such a high likelihood of having a bad outcome for the patient. Radiation necrosis is a bad outcome from our perspective. So we've seen very low rates of radiation necrosis, very low rates of tumor progression with salvage, surgery, and brachytherapy. So that's why we've moved towards that. But I think from a composite endpoint, that's something that you have to think about. It's not just the local failure. It's local failure plus radiation necrosis. And that's not insignificant. Again, as I mentioned, Manesh likes to get, as you get close to a flip of a coin, you're not doing the patient any benefit. You might as well just flip a coin and walk away. So.